the in thing in today's total hips. So I'm going to give you an overview of what metals are we using, what are the coatings, what are the different types, and what are the newer advancements in the same. So when we talk of metal composition, titanium alloys, titanium, aluminum, vanadium alloys are proving to be better than COCR because it is more biocompatible, it has a lower modulus of elasticity than as similar to a cortical bone, rather than using COCR, which are hard, lead to increased stress shielding and thigh pain. Surface coatings, whatever we may use, the initial fixation of the implant is primarily important because a micromotion of less than 20 microns can lead to good ingrowth or on-growth. For on-growth, the stems are usually plasma sprayed with metal powders, or they are grid blasted, hammered on with hard abrasive particles of aluminum oxide, which leads to a roughened texture. For ingrowth, there is fiber mesh sintered beads or porous metals with a pore size of 50 to 400 microns, which lead to better ingrowth. These are the coatings: grid blasted, plasma sprayed, titanium, sintered beads, HA coating, Gription, trabecular metal. Wockhardt was one of the first in 1977 when pure titanium was sintered onto the titanium alloy with a pore size of 250 microns. Then came Diofix in 2003 wherein Wockhardt was coated with hydroxyapatite layer. Gription came into being in 2009 where titanium sintered beads had an increased porosity, 80% of the surface volume being porous with an increased coefficient of friction. Trabecular metal, though appearing to be new, they have been in the market since 1997, where we use porous tantalum, which is similar to cancellous bone with 80% porosity. These are the elements of the cementless stem. We all know of them. This is an important paper by Mont Group in 2011, which describes 6 types of uncemented stems. Type 1 uncemented stem is a single wedge stem wherein it tapers down mediolaterally, but it is flat in the anteroposterior plane. Hence, it leads to a mediolateral capture, and in the lateral view, it is leading to a 3-point fixation. It is proximally coated and uses broach-only technique. It has 99% survival at 20 years. Mind you, the only reason for failures in type 1 stems, that is Bencox or taper lock stems, is in use of with Dor type A canals, wherein the stem engages early into the cortex, and therefore the porous coating is not engaged with the metaphysis. In these cases, preferably ream and then hammer. In type 2 stems, they are double wedge, that is mediolaterally tapering and anteroposteriorly as well tapering. Their intention is not to fit but fill the metaphysis in anteroposterior and mediolateral plane. It is proximally coated, it uses reaming and broaching both. 100% survival at 20 years, only problem being thigh pain in 12% of patients, examples being the summit stem. Type 3 stems are the tapered stems, very popular these days. Unlike type 1 and 2, they are smoothly curved down rather than abruptly changing their taper. They are surface coated proximally and distally, and they fit at the metadiaphysis. Type 3A is the Mallory head stem. It is conically designed with rounded corners. It has got proximal wings and fins for better rotational stability, 99% survival at 10 years. 3B are the popular Wagner stems, conical design with multiple longitudinal splines for better rotational stability. They mainly use for distal fixations, and you can adjust the versions for the same. Type 3C stems, very popular in European countries these days, have a rectangular flat cross section, and they have an 8 anteroposterior as well as a mediolateral taper. They fit at the metadiaphysis level and not only at the metaphysis. They ensure fixation with 3-point stability and fully grid blasted. That's what we use with broach-only technique. Very good survival rate. Examples being Bencox, Joy-Muller, and the CLS Protorna. Very interesting to know the development of these stems. Type 4 uncemented stems are the cylindrical, fully coated stems, AML being an example. They are essentially diaphysically fixing stems. The only problem being stress shielding. Why that happens is because if you have a distally holding stem, the proximal femora is not loaded, and that leads to osteolysis. 4 grades of stress shielding. As you can see, grade 1 is when you see a lytic area in the medial neck. Grade 2 is when the LT is osteolytic. Grade 3 is when you see the osteolysis going distal to the LT. And grade 4 is when you see the osteolysis entirely around the stem. Type 5 uncemented stems are the modular stems, the Arcos, the Revitan, and the S-ROMs. The advantage is that in dysmorphic stems, you can ream the canal differently for the metaphysis and the diaphysis, proven to be very successful at 10 years with 99% survival. Type 6 uncemented stems are the anatomic stems. They have a bow, they are conically designed. They are essentially meant to fill the canal, but unfortunately, they don't have the clinical success as desired. The newer kid on the block, the short femoral stems, the rationale for the development of the same has been it preserves bone stock, hence revision is easier. It does not have a thigh pain because there is no distal stem extension. There is no evidence of stress shielding because you're directly loading into the metaphysis itself. There is no proximal distal mismatch because there is no distal extension. And in newer approaches, they can easily be used in direct anterior approach, for example. Multitude of short stems being available. McTighe gave a classification which makes a lot of sense. The head stabilized, which are resurfacing procedures. The neck stabilized, which use the neck cut, which is very much proximal, and you load an implant in the calcar region. And the metaphysically stabilized, which are usually the conventional short stems, which are gaining a lot of popularity. The Mont classification again is similar, femoral neck only, calcar loading with a lateral flare, and type 4 are the shortened, tapered conventional stems. So these are the column stems that have been used. They are not fully investigated, though we have a 10-year data of good survival, but they have got a limited use. This is the proxima and the meta stem with a proximal neck cut. The shortened conventional tapered stem, very popular these days. They are either trochanteric sparing or harming. By definition, they have a length of less than 120 mm. Examples being Bencox, Trilock, Taperlock, Microplasty, and the ML taper. They have been well investigated and have a 98% survival at 10-year follow-up. Now the rationale for these is we have got a 3-point fixation in conventional stems. Short stems have the principle of wedge fixation at 2 points. These 2 points are usually located at the metadiaphyseal level, as you can see here in the diagram, and that's where it gets hitched or pegged. It is either 2D or 3D depending on where the wedging occurs. So that's about the short stems. Dual taper modular stems, which are bimodular, have a high revision rate because of increased modularity. It is mechanically failing. There's dissociation, there's galvanic corrosion, pitting corrosion, and crevice corrosion. Hence, they have not been in clinical use. Hence, my dear friends and seniors, it depends on what problem we have on hand. It needs to be measured as to where the bone stock is and what is the patient requirement. That's how you select your stem. I thank you for your patient hearing.